Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your college of entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is chlamydia. The epidemiology of chlamydia depends on the subtype. The most common form is Chalmydia Trachomatis. Trachomas, specifically, can spread from eye to eye by direct contact, fomites, or fly inoculation. Genital chlamydia is of highest prevalence in young sexually active adults and is spread by sexual intercourse. The most common cause of tubal fertility is chlamydia. Chlamydia pneumonia, on the other hand, is spread by respiratory droplets and is relatively common in children and young adults. Finally, Chlamydia psittaci is an avian infection and is transmitted from infected birds via a respiratory route. Chlamydia is a small obligate intracellular bacterium, and there are 3 species which we've already mentioned which cause disease in humans, which are Chalmydia trachomatis, Chlamydia pneumonia, and Chlamydia psittaci. The clinical manifestations of the 3 different types of chlamydia vary. So taking Chlamydia trachomatis first, in men this causes a urethritis or an epididymoochitis or prostatitis. In women it can cause urethritis, cervicitis, endometritis, pelvic inflammatory disease, or perihepatitis, and this is also known as Fitzhugh-Curtis syndrome. It can also cause conjunctivitis, reactive arthritis, or lymphogranuloma venereum. Chlamydia pneumonia causes an upper respiratory tract infection and is considered an atypical pneumonia. Chlamydia psittaci causes psittacosis. Genital chlamydia is diagnosed using the nucleic acid amplification test, or NAT, in urine and cervical swabs. It is more sensitive and specific than cell culture or antigen detection. Chlamydia pneumonia is diagnosed through serum antibody testing. The management of chlamydia again varies by type. For genital infections, azithromycin or doxycycline is effective. Chlamydia psittaci and chlamydia pneumonia require 2 to 3 weeks of tetracyclines or macrolides. Chlamydia trachomatis, leading to trachoma or conjunctivitis, is treated with topical tetracycline ointment or oral tetracycline or azithromycin. There are several complications to bear in mind when considering the treatment of chlamydia. Blindness can be caused by trachomas. You can also get fallopian tube scarring and infertility from Chlamydia trachomatis. And there's also the complication of rectal pain secondary to rectal strictures in LGV. So let's now try a question. So a 23-year-old man who has sex with men, MSM, presents with a 1-week history of acute right knee swelling and pain associated with limitations in movement. There is also complaint of pain on urination as well as bilateral painful red eyes. A diagnosis of reactive arthritis is suspected. What is the most likely result of the joint aspirate? So our options are negatively birefringent needle-shaped crystals, calcium pyrophosphate crystals, neutrophil count of more than 150,000, positive for C. trachomatis, blood-stained aspirate, or a neutrophil count of 25,000 with cloudy aspirate and a negative culture. So if we take each of these answers in turn, A is incorrect. So this describes negatively birefringent needle-shaped crystals. If you recall from our rheumatology videos, this is a classic description of what is seen when synovial fluid from a patient with gout is analysed. If you'd like to know more about gout, you can click on the link at the top of the screen right now to take you to our video. Answer B is calcium pyrophosphate crystals. This is a classic finding in people with pseudogout or calcium pyrophosphate disease. If you'd like to know more about this, click on the link at the top of the screen, which will take you to our rheumatology video on CPPD. C tells us that the person has a neutrophil count of more than 150,000 and is positive for C. trachomatis. Now, we are told that the timeline and the suspicion from the clinical picture is of reactive arthritis. What is described here in answer C is consistent with a septic arthritis, so a more acute picture, and this is with a classically very high neutrophil count and also a positive culture. So this is actually incorrect. This is not what you would see in a true reactive arthritis. However, if you'd like to know more about septic arthritis, you can click on the link at the top of your screen now to remind yourself about what is seen in a case of septic arthritis. And option D is a blood-stained aspirate. Well, you may see a blood-stained aspirate, it's unlikely, but it's certainly not specific or diagnostic for Chalmydia trachomatis reactive arthritis. And finally, option E, neutrophil count of 25,000 with cloudy aspirate and negative culture. So this is the correct answer because we've got a slightly high neutrophil count that's not too high, a negative culture, and yet we also have a bit of a cloudy aspirate as well. So it's not a normal aspirate. So this is the correct answer. If you'd like to remind yourself about reactive arthritis more broadly, you can click on the link at the top of your screen to take yourself to the relevant video in our rheumatology series.
Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.